nab-paclitaxel. It used to be a randomized trial, but they have now gone to giving it with the nab-paclitaxel. Then we have a phase 1 run-in of a drug called anatumumab, Avastin, and Pembro, compared to Pembro for mesothelin-positive pleural mesothelioma. Now, I know we've recently had a trial that reported in the second-line setting that anatumumab was inferior to actually tilnavulbine, to veneralbine. So I think it's important that we look at some of these drugs that maybe have not demonstrated what we needed them to be approved, yet we're starting to see them come forward now in a clinical trial setting where they're doing combination therapy. So I don't think we really knock anything out recently in mesothelioma. I think we just continue to build on some of the prior knowledge. Again, we see anatumumab now, and that's being offered with pemetrexed and cisplatin in mesothelin-expressed solid tumors. I'm mentioning this one because I know that it is accruing a lot of mesothelioma patients in addition to lung cancer patients. So again, an important trial, and again, looking again with the anatumumab and how to cleverly combine it and to push this drug forward. We look at autologous T cells, genetically engineered to target the surface antigen mesothelin. So we're hitting vaccines, we're hitting monoclonal antibodies. We also are looking at drugs that are just like, targeted drugs that are going to be very cytotoxic when they get to the mesothelin-directed cells. So we have the T cells that are genetically engineered. We have treatment of relapsed and/or chemotherapy refractory advanced malignancies by CAR T meso. So again, this is looking at some of the viruses and some of the vaccines that are going to be targeting mesothelin. I just have like a little graph here to show you some of the mesothelin therapies that have been tested that you may be familiar with. SS1P, which was developed at the National Cancer Institute, has gone on now to continue to grow, and this new LMB 100 is built on some of the prior knowledge. The MORAb 009, which is the anatumumab, is a drug that we had looked at, and it looked like it was going to show promise. It was a drug that was being brought forward by Merck, and that was being given with Ellipta and cisplatin. It showed positivity, but the drug company withdrew and decided not to proceed, go forward with mesothelioma. So it was disappointing, but again, this is a drug that has shown some activity, so I wouldn't be surprised if it comes out again, maybe in another iteration. The BAY 9493 43 is actually the anatumumab Avastin. This is one of the earlier iterations of that drug, the T cell therapy. CRS 207 is a vaccine drug. It uses the modified Listeria virus. And that had very positive results also being coupled with pemetrexed and cisplatin. The company decided not to move forward into a larger trial with Ellipta and cisplatin, but you'll see it's going to crop up later on in another combination. So people are really cleverly holding back, relooking, and starting to reintroduce the drugs in a different way than what we expected if we were going to follow like the traditional pattern of how clinical trials have been designed. So these are just some of the cancers that express mesothelin. And I think when you have a rare disease like mesothelioma, it's very hard to get pharmaceutical companies to invest. But if they know that some of the drugs that are in development are going to translate across to other cancers, they're more apt to invest first in mesothelioma. In fact, pemetrexed, they really used mesothelioma as a vehicle to get pemetrexed fast-tracked in the United States and moved on into other trials immediately in lung cancer, breast cancer, and some other drugs. So I think we can see that it's a good target and it's a good area for pharmaceutical companies to invest in. So there's another antibody-directed therapy that's non-mesothelin-directed. This is a trial that's actually taking place in Japan. It's YS110, and this is a trial that targets CD26. And CD26 is expressed on lining membranes, but it's more preferentially affected by malignant membranes. So it's already had its phase 1 testing. They tested in 26 patients, and 50% of those patients demonstrated prolonged disease. So it looks like a very promising drug. And again, this is only taking place in Japan. And I want to mention that Japan is very favorable right now when you look at it from a stock perspective and a pharmaceutical perspective for research and development. So we're seeing more and more pharmaceutical companies are moving into partnerships with universities and having their own freestanding drug development in this country. So I'm so pleased that Japan is investing in mesothelioma research because it's so important for all of us. So I just wanted to give you a little demonstration so you can see physically why we use antibodies. And antibodies, when we do these antibody drug conjugates, I want you to think about a drug being put inside a bullet, and that bullet is being directly targeted to a therapy. It goes directly into the cell, so you tend to have less systemic side effects. So, we mentioned that the antibody drug conjugates, like the LMB 100, the anatumumab, and now this drug that's being tested in Japan, all follow this antibody drug conjugate testing. So now tyrosine kinase inhibitors are another category of drugs, and we're familiar. Earlier we had discussions of taking place in lung cancer. We now have a drug called nitarinib, which is also BIVIF 1120, which is being tested in 2 different trials, one in combination with pemetrexed cisplatin, which, as you know, is the standard of care, versus placebo with pemetrexed cisplatin, and is followed by a maintenance or a placebo. So this is a very important trial because, again, this is looking now at frontline therapy. They also have a phase 2 trial looking at nitarinib in recurrent mesothelioma. So the company's strategy is to look at it in frontline and second line. So we see a lot of these drugs now are being given in many different, times during the clinical trial process. So it's interesting to see that type of development and that type of investment in research. I'm going to be talking a little bit more about some of the targets. So when we look at nitarinib, we know that it targets VEGF, which is vascular endothelial growth factor receptor. And if we remember from bevacizumab, this is a drug that cuts off the blood supply to tumors. And tumors, as they grow, require more and more and stronger blood supply. So one of the targets is to cut off this VEGF. Fibroblastic growth factor receptor is another one of the targets that is used by the nitarinib. And PGDFR, which is a platelet-derived growth factor. And we know that with malignant mesothelioma in particular, we see an overexpression of platelets. Patients tend to have higher platelet burdens than normal patients. So viral studies, we have a lot of virus studies going on in mesothelioma. We have the herpes simplex virus, which is treating patients with malignant pleural mesothelioma. We have an interpleural administration of GL-ONC1, which is a vaccinia virus. And then we have the CAR T cell receptor immunotherapy, which is targeting mesothelin again. And I know when we think of immunotherapy, we forget that some of the viral therapies are used also in immunotherapy because the virus actually, when we use attenuated viruses, it's because they replicate. They can get into the cells quickly. They can cause systemic reactions. So you'll see viral therapy and directed therapies as well as systemic therapies. And this is just an example of, the virus shedding and getting out to the cells. So you want to infect with an attenuated virus. You want an attenuated virus to be coated with an antigen that's going to go out and target mesothelioma. So some of the virus studies, everything that we've been talking about and hearing about, and it just seems that we're forgetting about chemotherapy, is that we need to bring chemotherapy and discuss chemo as well. Immunotherapy is interesting. We're not there yet. We're still testing. So I think that we can't really throw the bathwater out yet. We have to really take a look at some of the new ways of looking at giving chemotherapy. So navalbine, which is venerelbine, is really an important drug. We just saw that we just had a trial that failed that looked at anatumumab versus venerelbine in the second-line setting. And venerelbine, which many people thought was not really an active drug in mesothelioma, actually proved itself to be superior not only in median survival but in overall survival. So it's a drug that we really need to understand a little bit more about. And Perhaps it also has to do with the changing sort of face of the mesothelioma patient, being healthier, being younger. I'm not quite sure, but the historical controls do not hold up as well. So Medtronic chemotherapy is a very interesting way of dosing. It's a mathematical model, and rather than, we used to go for the highest level, when you do phase 1 testing, you're looking for the highest level with the maximum tolerated dose. When you look at Medtronic therapy, you're looking at lower doses, giving more frequently, and their mathematical models are used to determine what the dosing should be and how frequently a drug should be used. So if you think back at a drug like Cytoxan, we know that Cytoxan is used in breast cancer. It's used in it's an old cancer drug that you're familiar with. Well, Cytoxan is a cytotoxic drug. In other words, it's lethal to the cells. But when it's given with Medtronic chemotherapy, when it's given in lower doses and more frequently, it actually has an immune response. So I think that when we start to understand a little bit more about Medtronic chemotherapy, we may bring some of the old drugs back that we thought perhaps were not effective or perhaps were too toxic, and start to look at some of these models. So I think this is a very important study that's ongoing. It certainly is not a large study, it's not a global study, but it's a study that I think is important. And then we have a randomized phase 2 trial of venerabilin as a second-line therapy for patients with malignant mesothelioma. And the last trial we did was actually in 2009, and we have a randomized trial, and randomization is really how we really get at the data, and we really get a better understanding about how effective a drug is. So I think this is an important drug. So checkpoint inhibitors, I don't want to beat a horse to death today because I know we've talking about checkpoint inhibitors and we've talked about immunotherapy, but I just thought that, just to take a look at the slide where you can see, where this falls in, how this works. And checkpoint inhibitors are, again, being used in combination and as single agents, and they're very important in terms of clinical trials today. So some of the checkpoint inhibitor trials, we have a phase 3 open label trial of nivolumab in combination with ipilimumab versus pemetrexed with cisplatin or carboplatin as a first-line therapy. Now, I think that we have to remember is that, some of these drugs, again, were not as effective in phase 2 studies when we looked at them as a single agent, but now in these combinations, we certainly may see something better. We have a phase 2 study of PD-L1 ligand durvalumab in combination with chemotherapy with for first line of unresectable mesothelioma. So immunotherapy coupled with chemotherapy perhaps might be more effective than either of them as a single agent. And the phase 2 randomized trial of Pembro, I understand they have one slot left and they'll finally have that trial completed. And I think that's a very important study as well, because we're already starting to build on this study before the results have been published and analyzed and completed. So it's good to know that this trial is going to be finished. We have a phase 1b trial of pembrolizumab with nitarinib. So again, the drug that had 4 different targets combined now with a PD-L1 receptor, totally novel, very new, and this is going to be an important drug to move forward and to take a look at. Ipilimumab with nivolumab in the treatment of malignant mesothelioma. Ipilimumab is actually a CTLA-4 inhibitor. Nivolumab is a PD-L1 inhibitor. The combination may prove to be better. Now the CRS-207, which I mentioned earlier, which was the Listeria vaccine, and that targets mesothelin, that's now being combined with pembrolizumab in patients who have been previously treated with mesothelioma. So now we have a virus, we have a PD-L1 inhibitor, so this is a very novel type of treatment. And again, interesting because we know that we've seen activity in both of these drugs in mesothelioma, but certainly not in a combination. So that'll be interesting to watch that go forward. Again, here's another drug, defactinib. We know that had a global trial, did not reach its endpoint, was not approved, but now it's being given in combination with pembrolizumab for solid malignancies. So again, another drug brought back out, moved it forward into a clinical trial in combination. So I think this is another interesting trial to keep an eye on. We have tremelimumab combined with an anti-PD-L1 MEDI 1736. Tremelimumab, again, was another trial, didn't meet a primary endpoint, had been knocked out, and now it's being given in combination with an anti-PD-L1 inhibitor. So just keep reiterating that point that things are coming back and being looked at in different ways. Ipilimumab and nivolumab in the treatment of malignant pleural. It's a phase 2 study. And then we have a phase 3 double-blind placebo-controlled trial to evaluate the efficacy of nivolumab in relapsed mesothelioma. So looking at it in frontline in combination with cisplatin and Alimta, and now looking at it now in relapsed mesothelioma. So I wanted to make sure that I brought up some surgical trials. So I wanted to talk a little bit about the window of opportunity trials. So window studies are trials in which new compounds is given between the diagnosis and the standard treatment. Window studies offer the possibility to evaluate the activity of agents in unbiased conditions and to obtain pharmacodynamic and predictive parameters. The challenges are patient safeties and patient ethics, because usually window of treatment of drugs are not really given not really given as a treatment modality, but they're really given to learn more about the drugs. You have an opportunity to have a biopsy, to give some drug, and then to go back into surgery and see what your initial biopsy looked like, and then your biopsy after having given the drug, and look at the levels of tissue penetration. Certainly some of the window opportunities, though they were not designed for efficacy, we are seeing that some of these drugs are proving efficacious, and we're seeing with CT scans being done prior to surgery that there have been responses observed. So though it's not designed for that purpose, it certainly can serve as an additional purpose. So again, we're looking at some of the drugs that we're looking at in treatment. We're looking at the anti-PD-L1 Pembro in patients with resectable malignant mesothelioma. So that's good because we'll be able to see what the tissue penetration is and, whether it will have a long-term effect and whether it's going to, whether we'll see prolonged survival or lengthening of time to relapse in a surgical patient. We have the Medi 14736 or plus tremelimumab in surgically resectable malignant pleural mesothelioma. So either a single agent or a combined agent given prior to the surgery. We have another surgical trial to determine if it's feasible to recruit into a randomized trial comparing extended pleurectomy decortication versus no pleurectomy decortication in malignant mesothelioma. So, we have a lot of surgical trials. We talk about surgery all the time in mesothelioma, but the truth of the matter is that we have very few randomized trials, and randomized trials are the gold standard. So this is important that we have this trial, and I think this is going to give us some very good information, because as we begin to move forward with medical trials, knowing what the true survival and what the difference is in surgical trials will really help us to decide whether patients should be going to surgery or getting chemotherapy, and perhaps really understanding who that person is that should go to surgery or medical oncology. We have a phase 1 trial of adjuvant pembrolizumab after radiation therapy for lung intact malignant pleural mesothelioma, and that's with or without chemo or lung sparing surgery. So this is surgery or medical therapy with adjuvant pembro. We have a phase 1 study of cytoreductive surgery and hypothermic intraoperative chemotherapy with PEM-CIS for malignant pleural. So this is when you have a patient open on the operating table and you're giving them interpleural chemotherapy. It's a heated perfusion. It's proven itself out in peritoneal mesothelioma to be a very effective strategy. But in pleural, we don't have good randomized data. We have certain centers that use this only as their standard of care, but it has not proven itself out in any sort of a randomized form. So it's something that should be considered experimental yet and not standard of care. We have chemotherapy followed by surgery and neoadjuvant hemothoracic intensity modified radiation therapy, IMART, for patients with malignant pleural mesothelioma. We have surgery for patients after radiation, which is called the SMART trial. So the SMART trial is what they do is they give a modified radiation therapy to the chest, Then they take out the lung because they believe that the radiation is sterilizing the chest cavity. This has been championed up in Canada, and now there's a number of centers in the United States that are doing a randomized trial for this. We have a pilot study of the feasibility of interpleural photodynamic therapy in multimodality treatment combined in extended pleurectomy decortication, chemo, radiotherapy in patients with malignant pleural mesothelioma. We're actually doing a couple of adjuncts to this. So we're doing a photodynamic-based surgery. We're giving chemotherapy afterward, and we're giving radiation. So this is new, adding the radiation into this treatment protocol. Melissa Culligan, who's actually is here, has really championed doing some of these randomized trials in surgery. And this was Melissa's trial actually when she was at UPenn, which is a randomized trial of radical pleurectomy and postoperative chemotherapy with or without this photodynamic therapy for patients with epithelioid malignant pleural mesothelioma. So this is an important trial because we'll get the answer whether this photodynamic therapy works better than regular extended pleurectomy decortication, because oftentimes we have, we sort of promote some of these surgical procedures because they work, but I think what's happening is a lot of the senior surgeons, they've gotten better. So we don't know if the adjunct is really doing something or their surgical skills and their surgical expertise, having operated on so many patients, are what's pushing the envelope forward. There's a first-line immunotherapy using Wilms tumor protein, which is WT1. It's a dendritic cell vaccination for malignant pleural mesothelioma. So this is a trial that started at Memorial Sloan Kettering, where it was a randomized trial giving WT1 vaccine to patients following surgery, and this has now gone forward into the first line, into a frontline trial. So again, it's a trial that WT1 is expressed mainly in epithelioid mesothelioma. It's an important target. Despite our best efforts, there remains only one approved regimen for the treatment of malignant mesothelioma. We must be cognizant that there have been a number of large-scale phase 2 and phase 3 trials that have not met their primary endpoints. There'll be a role for immunotherapy, but qualifiers have yet to be determined, and ongoing trials must be analyzed to enable us to use these expensive new therapies in an ethical manner. So I'm constantly on my soapbox, but I want this opportunity just to say that our patients are clamoring for immunotherapy. People are prescribing off-label. Patients are paying for this. And if we can really hold back, encourage patients to participate in clinical trials, we're going to get the answers. We're going to do what's right for the patients and what's right for the development of drugs and clinical trials. Thank you.